Can you speak more to the role of inflammation in depression? I know that there's the inflammatory cytokine model of depression. I've even seen some data suggesting that anti-inflammatory drugs, like NSAID drugs, can, in a certain subset of the depressed population, treat their symptoms. And then even SSRI drugs have these pleiotropic effects. They've long been shown to be, or known to be, have an anti-inflammatory effect.
Yeah. So right now, the inflammation hypothesis for depression and even bipolar disorder, because mood disorders in general, and for clarification, bipolar disorder is when you have these highs and lows. So people describe them as manic or hypomanic episodes, but more so they're predominantly depressive episodes. There's been a lot of literature to say, is inflammation a causative factor for these? And by that I mean, does inflammation cause the depression? Or is inflammation just a feature of it, where in a depressed state, whether peripherally or centrally, you have elevated levels of inflammation? It's hard to say. Right now, the literature isn't definitive in saying that this works or not. And what you alluded to as well, too, there's trials looking at anti-inflammatory drugs for depressive symptoms or depression, usually as an adjunct to the antidepressants. And the results are conflicting. It shows that it works sometimes not, particularly in bipolar disorder, not as much. And it's traditionally more treatment resistant. And they've even tried to do subgroups of population where they take peripheral markers and say, who is the inflamed group, give them the anti-inflammatories. Some of those studies have shown that it works, some not. So I think there is a basis, and it goes back to the definition of depression. It seems to work in some people that perhaps there is more of that inflammatory predominant picture, but it doesn't seem to work in everyone, where it doesn't seem that it's this overarching treatment that will just cure all. But I do think that there's merit in looking into it more to see if there are subpopulations. And in the future, I would love to see this, because right now for psychiatry in general, even beyond depression, we diagnose conditions purely based on symptoms. So that would be akin to you going to the hospital, having chest pain, and they say you have chest pain. They don't say you have a heart attack. They don't say you have a clot in your lungs. You have chest pain. And we're going to treat you with this medication that we hope works. I would love for the future to say, I have these symptoms of depression. Let's do a test and see what kind of depression you have. Let's kind of get this into something more specific, and let's get a treatment that works specifically for you. Because again, it circles back to what I discussed, and why our treatment isn't perfect is because we're treating chest pain. We don't know what that chest pain is. We didn't diagnose it as a heart attack. We didn't diagnose it as, another medical condition. We're treating it at that symptom-based level, which I think we need to kind of get a better understanding of what's causing that, what's perpetuating that, and that way we can intervene more effectively.
Yeah. How do you, because I think sometimes we run the risk of medicalizing natural human emotions. So how does that, how do we stratify clinical medical grade depression as compared to, I occasionally get depressed and I don't feel like getting out of bed with the same vigor that I do on other days. How do we stratify the two sort of grades, I guess?
Yeah. And I think that's a great question, because I think you want to feel the highs and lows. If something bad happens, sometimes you want to feel low. It's part of being human, right? And you don't want to be on this, if you're to draw the mood spectrum of having highs and lows, you don't want to just be a straight line and not be able to feel happy and not be able to feel sad. There are times where you want to feel those emotions just to be human. So I think the defining factor is really speaking to the patient in front of you and talking how does this impact your day to day? Can you still function with how you're feeling? If the answer is yes, it's hard, in these days, maybe you can't get up, you can still go with that. You can, next day, I'm going to make up for the work I wasn't able to do, sort of thing. But if it's getting to the point where you're not able to do the things that you like, and that there's something almost just blocking that ability, I think that's where the conversation needs to be had with your provider, whether it's your psychiatrist, whether it's your primary care doctor, about, hey, this is impacting the life that I want to live, and I want to do something about it. So whether that's therapy, whether that's medications, whether that's exercise, whether that's modifying your diet, that's what your doctor should be there to do, be that resource for you. But the patient as well, too, we should let them have the autonomy to make that decision and say, hey, this is impacting my life. Now I want to intervene. Not, hey, I've been feeling sad today. I should start a medication or something. Because you're right. We don't want to over-medicalize stuff. We don't want to medicalize the human experience, because it's important just to be a human being.
Yeah. Do you think we have an overprescription problem in this country, or like, where do you stand on that debate? You know, either these drugs are being overprescribed, or we actually need to broaden our diagnostic criteria and make sure that more people have access to them. I've heard divergent viewpoints when asking that question to other mental health care providers.
Yeah, my view on that would be this. I think we are, and to restructure that, is we're too focused on treatment and we're not focused enough on prevention. So I think right now, perhaps there is evidence to suggest that antidepressant prescriptions are increasing, particularly in younger populations. And it's hard to say, you know, is that overprescribing due to increasing depression? Is that just due to kind of prescribing antidepressants for everything sort of thing? I think where we would see the most benefit, though, is in these population of people that are depressed. You know, yes, we need to focus on treatment and help them feel better, but it doesn't just stop there. It's not that once you're better, stuff is okay. We want to make sure that on both ends, you have the treatment population getting better. You have people that don't even have depression yet that could progress to developing depression. I think we need to focus more on the risk factors for relapse of depression and the risk factors for even developing depression. So not to say that these lifestyle factors like exercise, diet, and sleep are the sole causative factors for depression, but how I view it is that these are the fundamentals for your health, not even just mental health. So if you have someone that's in a depressed state, for instance, they're started on medications or therapy, they get better, and you know, maybe they stay out of that depressed state for a few months or even a year or something great like that. But the underlying fundamentals of their diet, their exercise, and sleep remain unchanged. I think that your risk of developing depression later on is much higher. And we don't have a lot of data to look at these long-term studies to say, you know, after we get someone to remission, then we optimize their lifestyle parameters. What's the risk of relapse? Because what you see a lot with depression is relapse. And a lot of the guidelines after times people have multiple episodes of relapse, they end up being on antidepressants for their whole life. And what I like and what I've heard from patients is that these lifestyle factors give you this locus of control. Whereas sometimes when you're prescribing medications, it's, you know, I need this because I feel broken, which is not necessarily the notion, but that's how sometimes people feel. Whereas when you give someone an exercise prescription or talk to them about that, they feel like, you know, I'm in control of me. Even if something bad happens, I feel like I can get out of this. And that's important too, because you want to have that internal sense of control over yourself, because it allows you to have better treatment outcomes. It allows you to engage in more things. So to your question, I think I had a long-winded answer, but I think perhaps there is a little bit overprescribing, but I think we're not focusing on prevention of these episodes and prevention of recurrence of these episodes once they do happen. We're too focused on treatment and these new fancy drugs with different mechanisms of action when you're tweaking just small receptors and things like this, when we know there are ways to reduce the risk of depression. And they're a lot simpler than all these different pharmacology and things. So I think that's the main point.
Yeah, no, I love that perspective. I mean, I had Dr. Judith Joseph on the show recently, who just wrote a book on what she calls high functioning depression, which I think is such a cool concept. But when I asked her that question, there was a bit of disagreement because, you know, I can't help but look at figures like the fact that 1 in 4 women over the age of 40 is on some kind of antidepressant drug. And to me, it's like, you know, very clear that there are people being prescribed not just those kinds of drugs, like that category of drugs, but other antibiotics. I mean, we talk about all the time, for example, that, you know, that would be probably better served taking a more, you know, holistic approach. But her perspective, which I respect, was that, you know, actually, I don't see that. I you know, from my vantage point, we need to broaden access to these drugs so that more people essentially can get on them if need be.
Yeah, and I think my viewpoint for that is remembering our role as a physician is to inform the person in front of us of what the options are for treatment so that they can make an informed decision. So whether that patient chooses to have an antidepressant, whether they choose to do therapy, whether they choose to do exercise or diet, I think there is still that paternalistic culture in medicine in general, psychiatry included, where sometimes that we feel we know the best option for the person in front of us. But I think we need to remain in this humble position of saying we're educators for the person in front of us. That's what we went to school for, was to learn all these different things so that the patient in front of us can make that decision. So whether that's, as I mentioned, any of those options, we want to help facilitate that. And I think where there's a little bit of a disconnect is it's a lot easier for us to prescribe an antidepressant or refer someone to therapy, which again, therapy is hard too, because there's not a lot of resources. It's very expensive for people. But there's not a lot of connection to the exercise, diet, sleep realm. Again, providers themselves aren't very comfortable speaking about those things, nor do we have a lot of resources to give to someone who wants to really get into it. So I think when we look at antidepressants and therapy, we have more streamlined ways to refer someone to that and get involved. Whereas our lifestyle ones, it's more of, again, go exercise, go do that, which they know that. The patient in front of you knows that. It can be condescending to hear, you should just go exercise. And I think that's why sometimes, especially in short form content, when I share stuff online for exercise and stuff, it can be taken poorly because it comes across as, well, just go exercise. But that's never the message. It's let's educate physicians, starting from medical school to residency to being a staff, on how to talk about this. And let's set up the system so that we can actually allow a patient to engage and be successful in some of these different things.
Hey, if you like that video, you need to check out this one here, and I'll see you there.